All right, let's move on to case number 4. Let's keep it clean. This case comes from Rammy Assaf, who is a pediatric emergency medicine fellow from Harbor UCLA Medical Center in Los Angeles, California. This is a 17-year-old female with a stated history of recurrent cellulitis who presents with red, hot, and swollen hands and feet. Her left hand is by far the worst this time, but it's happened 4 times in the past, and it seemed to improve after admission and IV antibiotics. She had recently been admitted to an outside facility, and after 2 days of IV Vanc and ceftriaxone, she left AMA because she wasn't getting better. So she's your patient now. The swelling and redness usually involves one or both hands and feet, and sometimes it extends up to the forearm. There's a burning pain, but no cyanosis or pruritus, and she's never had fever or any systemic symptoms, including joint or ocular complaints. She denies any recent trauma and has not used any new soaps, detergent, creams, or jewelry. She is not taking any regular medications or using recreational drugs, and there's no family history of rheumatologic disease. The rash on the left hand and forearm, which I'm going to show you in a minute, is erythematous, warm, and exquisitely tender without any secondary changes. And secondary changes include scaling, crusting, fissure, ulcer, or excoriation. Flexion or extension of the fingers are limited due to pain. Labs that were obtained included normal CBC with differential, electrolytes, and CK. She was not pregnant. Her ESR was 30, the CRP was 3.8, and the ANA screen was positive for a 1 to 320 with a speckled pattern. Here is the rash. So what's the diagnosis? Is this A, Raynaud's phenomenon, B, erysipelas, C, contact dermatitis, D, erythromelalgia, or E, palmoplantar hidradenitis? 30 seconds. The correct answer is D, erythromelalgia. Rheumatology helped make the diagnosis and assisted in proper pronunciation. She required no additional antibiotics, and the family was agreeable with an outpatient pain plan and room follow-up. So what is this? Well, erythromelalgia is a rare skin condition characterized by recurrent episodes of intense burning, pain, redness, swelling, and warmth of the distal extremities. It can develop at any age, and it generally relapses over time with flares lasting hours to days. Some patients, unfortunately, have a chronic, debilitating course. Why does it happen? Well, we think it's maldistribution of blood flow, which leads to an increased AV shunting and decreased nutritive flow, which causes local hyperemia and hypoxia. Heat and exercise may lead to flares, with symptoms often worsening later in the day. Management is largely supportive, including elevation, cooling, topical lidocaine or capsaicin, aspirin, naproxen, and or gabapentin. The patient had the primary genetic form that is caused by disordered neuronal sodium channels. Secondary forms have been associated with hematologic, oncologic, infectious, or autoimmune diseases. Skin biopsy is not useful, and the diagnosis is generally confirmed by smart people and genetic testing. So Raynaud's phenomenon, which I guarantee all of you have seen, is due to vasoconstriction, not hyperemia, and there was no history of the episodic pallor and cyanosis. Erysipelas is a cellulitis and lymphangitis of the face and lower extremities caused by group A strep or staph species. The lesions are erythematous, edematous, hot, painful, well-demarcated plaques, and that's due to dilated superficial lymphatic channels. Contact dermatitis is characterized by red patches and peeling skin immediately following a triggering exposure. And palmoplantar hidradenitis has red, tender nodules on the hands and feet, and it's associated with waiting in pools and saunas. They resolve on their own over 1 to 2 to 3 weeks.